I just wanted to, it's a brief presentation really. I wanted to share some of our experiences in the UK. We're at General Hospital, the Royal Bournemouth Hospital. We're a 900 bedded general hospital, and we're also the regional centre for many things, including cardiology, interventional radiology, urology. So we're a kind of big hospital. From next year, in fact, we're going to be a university hospital as well. So we're quite big, but we're very general. The only thing we don't do is paediatrics, but we do everything else. We've got 20 staff radiologists, 3 CT scanners. We've got 1 64-slice CXL and 2 Genesis scanners. So we're a fairly typical large hospital in the UK. So about 5 weeks ago, when COVID-19 started to, well, at least we really thought it was going to hit, we basically cancelled everything pretty much. We were told that there was this huge wave of cases coming. London had already had lots of cases, so we were told it was coming to us. So we cancelled pretty much everything. So all outpatient scanning was pretty much cancelled, apart from the very most urgent cancer scanning. And then we directed all of our resources to staff 2 inpatient CT scanners, basically. We went down from MRI, we went down from 4 scanners to 1. And we basically, we usually have 1 inpatient scanner, so we had 2. So we did leave 1 outpatient scanner for very urgent cancer cases, but that was it. So we're pretty much only inpatient CT, we diverted everything to. We stopped all cardiac CT and MR completely. 50% of the radiologists were sent home, basically, to home report, and the system immediately crashed, because suddenly there was large numbers of people home reporting, and the maximum bandwidth that the remote access server could support, which was designed for basic IT people dialing into the system, was 15 megabits, and it couldn't cope with, suddenly 10 radiologists dialing in, pulling up images. So the IT were very good, and they replaced the server, and now we can if our connection will support it, we're up to 300 megabits from home. So that was solved. But so basically the rest of the hospital as well went into complete emergency mode. They cancelled everything pretty much. All elective cardiology was cancelled, everything. So the only PCI carrying on was primary PCI for acute MI. Everything else was cancelled. All non-acute surgery was, all non-urgent surgery was cancelled. So almost everything. Outpatient visit, the outpatient department was closed. The physicians were all redeployed to full shifts for acute medicine. So rheumatologists, were then becoming acute medical physicians, and they were all on shifts, so staffed by consultants 24 hours a day. So it's a huge change. And so that was a reorganization in the main hospital. But then in radiology, we were kind of all making it up as we went along, as the world tried to get used to this. And there were guidelines came out from the surgeons in the UK. I'd probably not discussed necessarily very much with radiology, that all patients who were going to have any acute surgery, or any surgery in fact, needed a screening CT chest to make sure they didn't have COVID-19. So we switched to a system where we were suddenly, every patient who was going for surgery, and there weren't that many, was having a CT of their chest. Our experience of that, and I'm interested to hear what other people were if the patient was well and asymptomatic, we really didn't pick anything up. We picked up pretty much no unexpected cases, and we've actually abandoned doing that now. If the patient's asymptomatic, we actually don't do that anymore. But that was what we did initially, because we thought that was a good idea. That's what the surgeons thought was a good idea, but their advice has changed now as well. One thing we did do, this was when we went into emergency mode, and we still do, because we feel it's pretty useful, is we do all acute abdomens, we do a CT chest, because we found that it's quite a common presentation of COVID-19, particularly in young people, it seems, is to present with abdominal pain rather than chest symptoms. And so we do a chest on all abdo-pelvises on CT, and we've found quite a lot of unexpected COVID on that. So we still do that. So basically we were all in emergency mode, and we waited for this huge tsunami of cases to come. and everyone was just waiting. And I have to say that the kind of good news is it never quite happened. Now we've had a lot of COVID, but we've never had that huge wave we were expecting. And I'll just try to explain why. I think this is the cases of COVID across the UK. This is just zoomed in on the south of England here. As you can see, it's very much London-centric COVID, or it's certainly big conurbation. So London, the West Midlands, is basically people where there's a lot of people living close together have a huge incidence of COVID, and particularly London. And London was about 2 weeks ahead, and still is about 2 weeks ahead of us. And they'd had a huge number of deaths. They'd had completely full ITU units, and they were 2 weeks ahead. So basically the whole country kind of went into lockdown. And what's happened is that we've never seen the surge of cases that they had in London. So our ITUs are not full. We've gone up from a capacity of about 15 beds to potentially 40. But we're not using anything like that number. We're sort of at normal ITU capacity, and we've just never had that surge. But as I said, we still see a lot of COVID. So we've not as much as London would, but we can cope. But we've seen a lot of COVID, and this is kind of a fairly typical thing that we see. This is someone with fairly mild symptoms. I haven't shown the chest X-ray, but chest X-ray was normal, but they strongly suspected COVID clinically, and we've got these patchy ground glass changes at the left base. They eventually tested PCR positive for COVID. I can't actually prove that these changes are good of COVID, but we've got a PCR positive person with subtle ground glass changes. So I think that's what it is. Of course, in our current clinical environment, the pre-test probability for COVID is so high that pretty much if we see any ground glass change, we're kind of calling it COVID, even though we accept that there may be other viruses like adenovirus or respiratory syncytial virus or whatever, or influenza even, that might cause similar changes. But it's just in our current environment, we're calling them COVID. This is the other end of the spectrum, gross consolidation and ground glass change throughout both lungs, with a lot of thrombus in the pulmonary vessels. I'll come back to that later. I'm calling it thrombus now rather than emboli, because I'm not entirely convinced these are emboli. But this poor woman was 45 years old, came in looking like this, and had and subsequently arrested, and she was essentially brain dead. And so we're seeing not many cases like this. Luckily, London are seeing a lot of cases like this, but we're seeing some. One issue we have had, and I've got some other experts on the line who are much more expert at this than me because they developed the software, is we use our standard protocol for all CTPA studies, all outpatients and inpatients at our institution, is using lung subtraction. So we do a pre-contrast, post-contrast, and we subtract the two to get iodine maps of the lungs. And we find that in the normal population, we find that fantastically useful. Interestingly, in COVID, because there's so much consolidation and ground glass in the lungs, what the software excludes those bit of lung from the analysis. So we can only see the relatively normal bits of lung for the perfusion map. So this was that lady I showed you earlier. So most of the software has excluded most of the lungs. So in COVID, I think there needs to be some just slight change of the software to allow us to see iodine concentrations in the consolidated lung as well. It's not a problem we normally have, because in the normal population, pulmonary embolus doesn't usually cause infarction because the lungs have a dual blood supply, so you don't usually see an increased density of the lung, so it works fine. But in COVID, the primary condition is lung consolidation, so that causes a problem. Something we're seeing really a lot is people who have focal consolidation in the lung with COVID. We see filling defects in the blood vessels, in the arteries, in the same area. And these just, to me, certainly don't kind of look like emboli to me. You get this is an example of a thrombus in the right lower lobe pulmonary artery here in someone with right lower lobe consolidation. And there's this kind of irregular filling defect. It's just kind of not the filling defect that you normally get with emboli. And it's also localized only to the areas of consolidation. So, and there is some evidence that the COVID causes vascular changes. So I guess one possibility here is that at least some of these cases are not true emboli. they're actually in situ thrombus because of the virus. And it is incredibly common. We seem to see these all the time. And the question is, do you treat like a normal pulmonary embolus? Is it I don't think anyone knows the answer, but we're certainly seeing a lot of this. So just trying to think, and it's difficult because we're still in the middle of this crisis, but we're just trying to think of what went well and what didn't go so well. What did go well, and this is the experience of lots of other places I talked to in the UK, is that everyone in the hospital developed a kind of can-do attitude. People just wanted to sort things out. So people that were departments and people that had been obstructive suddenly became incredibly helpful, and actually we could just sort stuff out. So things like IT issues and information governance issues, things that used to take months, were sorted out in a few minutes rather than months and months. Believe it or not, I'm embarrassed to say we didn't have an order comms system before COVID, because the physicians were, for the last 5 years, have blocked implementation because they wanted to stick with paper, because they used paper to drive their workflows. And we said, well, the risk of COVID is too high. We don't want paper coming down to the department anymore. We don't want to allow physicians to come to the department anymore with paper. So you're going to have to go to order comms. There was enormous, very brief complaints for about a day, and then everyone accepted it, and now we're completely order comms. So that was good. We've got a very good service for reporting because we never saw this wave. We've got loads of radiologists, some online and some here, waiting for the studies. So we report pretty much 100% of all X-rays within 10 minutes, usually within 5 minutes, and we report almost all CTs within 30 minutes. So probably 99% within 10 minutes. So we're actually waiting for the images to come off the scanner. Now, in the hospital, staff morale actually surprisingly has been excellent. I mean, people are working well together. They actually quite welcome the routine of coming into the hospital rather than sitting at home, and actually it's been good. And the image quality has been, we found on both on our old 64 and our new Genesis, both the image quality has been almost always excellent. And we haven't, on our old 64 detector system, we haven't tried to kind of achieve the same low dose as we get on the Genesis. It's got older detectors and all the rest. So we are going for standard doses, so not super low doses, but it's still pretty low. We're around 1 to 2 millisieverts for chest, and because these are pretty sick patients and we want good image quality, we're not trying to push the envelope because we've got too much else to do. The nice thing as a radiologist, and I'd be interested to know what other people say, is that most of the patients have actually got something wrong with them, which is unusual because we often get the worried well. I think most Western countries do, but these are not the worried well anymore. These people actually have something wrong with them. No, it's bad that these patients are ill, but as a radiologist, it's quite interesting that you actually have something to report. So what didn't go so well? There was advice from NHS England regarding personal protective equipment, and that was very confused initially. First of all, basically the advice was only to wear masks and gowns and gloves if you think the patient's got COVID. Now that was becoming more and more untenable, given that so many of our patients did turn out to have COVID. So we had a situation where the radiographers were wearing no protective equipment. We then scanned the chest and it showed florid ground glass change, and then everyone felt bad that they hadn't been wearing a mask. So that was changed, and now for the whole NHS, every patient that any of us see, we have to wear at least a mask, gloves, and a gown if we're doing CT or whatever. So if there's an aerosolizing procedure, you have to wear a full filtered mask and everything. But mostly in radiology, we're just wearing mask, gown, gloves. One thing we've really noticed is that our throughput on our 2 inpatient CT scanners is less than it was on 1 CT scanner before, because we have to do so much cleaning. So if a patient has COVID or suspected COVID, we have to do a full clean of the scanner, which takes 45 minutes to an hour. If they don't have COVID, then we do a quick clean, which takes 5 minutes or so that's better, but it's really slowed our throughput. Because we haven't ever had this wave of admissions that we expected, we've had radiographers, radiologists, and physicians left with not enough to do, actually, if we're honest. So we're actually grateful for cases to report, because we just never got this wave that we expected. The big problem we are seeing is that patients with non-COVID who are actually quite ill are staying at home. They're not coming in, and we're starting to see conditions that I only saw when I was a young doctor. So we're starting to see late presentation myocardial infarct with ruptured VSDs, with ruptured mitral valves. It's conditions that I used to see a lot when I was in my 20s. We hadn't seen it for years, but we're starting to see it again because people are following the advice that they've got to stay at home, but that's been too successful, and people who are ill should still come into hospital, but they're not, and we're seeing perforated appendixes and all sorts. One thing that we have found is that although the morale is great for the doctors, the radiologists who are in the hospital, and I've been in the hospital all the time, it's been fine. The people at home have found it really difficult. They've found the morale's been pretty low. They feel quite isolated. They find it very difficult to talk to the clinicians. They find it difficult to talk to the other radiologists. So they can see the images okay, but they find it really difficult to communicate. So what are we doing now? So this is kind of 5 weeks on now. So we're trying to get used to the kind of new normal. So what do we do now? Although we never got the peak, we have to just adapt now to a sort of long-term situation, we feel. We actually are now doing actually surprisingly little chest CT for query COVID. We thought we would do lots of it, but we're actually not doing that much. We say we'll do it on anyone, but we haven't. The main indication seems to have shaken out to being it's useful to the clinicians when the chest X-ray is normal and they really suspect COVID. And then sometimes you see multifocal ground glass changes. These are symptomatic patients. It seems quite useful. It doesn't seem useful doing CT in asymptomatic patients, but symptomatic patients it seems useful. And we do CT for suspected PE, and we find in COVID, as I said, we find a lot of thrombi. We've started trying to recover, even though we're still in the middle of COVID, we're trying to recover because we've got potentially 4 months worth of outpatients that have built up. So we're trying to scan the backlog of less urgent CT and MRI cases, and we're using private provider capacity because our 2 local private hospitals have become NHS hospitals, and we're allowed to scan at those hospitals. So we're starting to do that. That's something that the whole NHS in the UK has done. We've got cardiac CT list now again. We realized that we were missing a lot of disease, and it was, it's not a good situation. We were having chest pain clinic was sending for exercise testing, which wasn't a good thing to do. So we're now starting to do cardiac CT again, and we're running 3 lists per week, and we're starting to a limited amount of cardiac MR. And we do a quick scanner clean after each patient, but we do a full clean, which takes 45 minutes if the patient's got COVID, essentially. So what would help us in the next time when we have another pandemic, because I hope I won't see another one, but there may be. I think it's highlighted that our scan rooms we're not used to dealing with infectious diseases. In fact, throughout my whole career as a doctor, and I'm in my mid-50s now, we've never had infections around us. We just don't see infectious diseases. So our scan rooms are not designed for it. So people are dressed in full protective equipment, and they have to then open the door with a handle, and then they de-sterilize the door, and we have to keep cleaning the handles and stuff. And I think our scan rooms could be designed differently with maybe some sort of automation. One problem we have had is we've had because we're trying to increase our numbers, we've had less experienced radiographers from main X-ray doing CT, and they're less experienced, they're less confident, and also they don't do CT as much. So they have really struggled in the stressful situation, not making mistakes, and there have been mistakes made with protocols and positioning and all the rest of it. And what would really help us is if that scanning process was automated. When it's really stressful, what you need the scanner to kind of take over. I mean, if Tesla can drive my car to work, then I'm hoping that Canon or whoever can drive my CT scanner, because I think it would just help in a really, really stressful environment. We do need better ways of working from home. At the moment, our home working is great for viewing the images, but we then can't communicate with everything. So what we need is some way of tying in the packs to systems that we can communicate with our colleagues and have the to have discussions with clinicians, because we can't do that bit at the moment, and that's the stress for people from home.